Welcome to this Bone Matter session on osteoporosis drug treatments. That's the medications that are used to strengthen bones. And this session is all about understanding more about possible side effects. Now, we know this is a really popular topic with our audience. You really want to do the best you can for your bone strength and reduce the chance of your bones breaking. But we know that sometimes people worry about side effects, either those that come perhaps straight away or the longer term health problems that they have heard might be caused by these medications. And you may read stuff in the media that's confusing. And sometimes people decide it's easier not to take a medication and depriving themselves really of the possible benefits. So we want to help you there, and hopefully this session will contribute to that. This is all about getting things straight, learning about the side effects, how to reduce them, and also perhaps the other options that might be available too. We're going to give you some hints and tips and really help you get these, particularly the rare side effects, into perspective. So I'm delighted today to be joined by an expert in the field, Dr. Alison Black. She is a rheumatologist seeing patients in her work and discussing these topics every day. And we're going to talk about some of these questions together. So welcome, Alison. Can I ask you perhaps to start by introducing yourself and your job and where you work?
Thank you. Hello, everyone. I'm delighted to be here. So I'm Alison Black, and I'm a consultant rheumatologist in Grampian. So I look after people with osteoporosis in Aberdeen, in Aberdeenshire, and Morayshire, and both in Shetland and Orkney as well. And I've been a rheumatologist very sadly since 1990. So I'm very old, and obviously have treated a lot of patients with osteoporosis over the years.
Thank you. That's great. Right, let's start by just reminding everyone that there are many different drugs available to strengthen bones, and we won't be able to cover all of them in this session. So do head over to our website and have a look at all of our fact sheets and other resources. We're going to be talking mainly about a family of drugs called bisphosphonates, and we're also going to touch on two other drugs, denosumab and Romosozumab. As I say, more in our fact sheets if you want to know more. But let's just begin by saying it's really important to remember that every drug will have some side effects. And when you look at an information sheet you get with your drug, there might be a massive list there, but many of these are unusual. And sometimes it's not even proven that the side effect is caused by the drug itself. It may have just been reported. So we're going to talk about that in a bit more detail later on. Let's start at the very beginning. So Dr. Black, can you just remind us what are the drugs that sit within the bisphosphonate family and how you take them?
So bisphosphonates are medications that bind into bone mineral itself and reduce the rate of bone breakdown and therefore prevent fractures. So these medications can either be in tablet form taken by mouth, or they can be intravenous preparations given by either a drip in the arm or a short time injection. The tablet forms include alendronate, risedronate, ibandronate, and these tablets tend to be taken first of all with alendronate and risedronate on a weekly basis, half an hour before breakfast with a large glass of water. You must have fasted overnight before taking these medications, and you must not take any other medications at the same time. It's important when taking these tablets orally that you remain in an upright posture after taking the medications. That doesn't mean you have to stand bolt upright for half an hour, but instead you must be either sitting up or standing, walking around. And it's not a good idea to lie down or to do a lot of bending forward after taking the medications. The ibandronate oral tablet is taken on a monthly basis, and on that occasion you must leave at least an hour before having your breakfast. Side effects of these medications are less common if you take them correctly. So I think it's very important to remember to have a large glass of water while taking the tablet to minimise the risk of things like heartburn and indigestion, and also to have your breakfast half an hour later for the weekly tablets and an hour later. Don't leave a longer fast because that makes you more likely to have some gastrointestinal upset.
Okay, so that's great. So we've heard there about all the different types of drugs that fit in this bisphosphonate family, and you've also talked us through some of the common types of side effects that people get with bisphosphonates, which are mainly sort of upset tummy, particularly indigestion type problems, aren't they? And some of the practical things you can do to try and reduce those happening and affecting you. So thanks for that. So a quick mention just of the names of a couple of other drugs that we're going to talk about. Can you just tell us how you take denosumab and Romosozumab? Because those are slightly different, aren't they? Not in the bisphosphonate family.
They're not. Both of these medications are antibodies, and therefore they're given by injection, an injection under the skin. And they both work on internal bone pathways, bone metabolism pathways, but different pathways. So the denosumab is an injection just under the skin, usually given by your GP practice nurse once every 6 months. And it's very important that it is given in a timely fashion every 6 months, as delays can increase your fracture risks once more. While Romosozumab is given by a monthly, usually self-delivered injection. It's actually 2 injections, one after the other, once a month for a period of 12 months, and then that medication is complete.
Great, thank you. Let's just go back a minute to the bisphosphonates. You talked about the things you can do to reduce the chance of indigestion problems. If someone has sort of bloating, tummy ache, when they're taking a tablet bisphosphonates, how do they know it's the drug, and what can they do perhaps to check that out?
Well, the first thing is you only take these bisphosphonates once a week or once a month in the case of ibandronate. So the side effects should really only be occurring around the time of taking the injection, in that 4 or 5 hour period after taking the injection, or taking the tablet. However, if you have side effects that occur throughout the week, perhaps you should consider whether it's the calcium and vitamin D supplements that you've been prescribed that are causing problems. And one way, of course, of finding out is, first of all, to stop the calcium vitamin D supplements for a few days and find out whether the symptoms settle down. And again, if you think it's the bisphosphonate, having a couple of weeks off and see whether those symptoms persist is a good way of telling whether the medication is causing the side effects or not. Stopping for a couple of weeks will not change your long-term future from your medication, and it will not increase your chance of fracturing in that short period of time.
That's great. So some really good tips there about what you might do in the short term. So let's assume that these sort of upset tummy or indigestion problems don't go away. What are the other options? Are there other drugs that you could take instead, or other ways of taking them?
Yes, well, first of all, from the point of view of the medication, if we're absolutely convinced that it is our bisphosphonate tablet that is causing us to have heartburn and indigestion, it is possible to be prescribed a medication called a proton pump inhibitor, a PPI. And these medications, you'll recognise these names as omeprazole, lansoprazole, for example. And these reduce the acid secretion in your tummy, and they can make it easier to tolerate oral bisphosphonate medications. And that's worth trying. Of the bisphosphonates, they're not all exactly the same. Some people will be upset when they take something like alendronate, while they might actually tolerate risedronate. So sometimes actually just ringing the changes in the bisphosphonate medications is worth a shot. But if you've done all of that and you've persevered and you really are having significant side effects, then the option of giving the bisphosphonate as an intravenous infusion or injection is one you should explore with your general practitioner. The zoledronic acid infusions, which are an annual infusion, usually once a year for a period of 3 years, they tend to have to be delivered by a specialist osteoporosis service. But some general practices do offer ibandronate by an intravenous injection once every 3 months, or again, you may have to go into the secondary care specialist bone service for that therapy, but it's certainly worth pursuing with your general practitioner.
And obviously taking the drug straight into the vein is going to stop that indigestion type problem. Are there any side effects people are going to get from an intravenous, getting a drug like this through a drip?
There occasionally people develop a flu-like reaction. They feel achy and shivery, and almost as though they have the flu, but I can assure you, you don't have the flu after taking it. The reaction can last for up to 72 hours, and it's usually only occurs with the first infusion, although a lighter version of the flu-like reaction may occur with subsequent infusions. It can usually be aided by taking some paracetamol, drinking lots of fluids, and probably occurs in about 1 in 5 people who take it, to a greater or lesser extent for the individual. Now, some people will feel a bit unwell for those few days, but it is only for a few days, once a year maximum. So most people do manage to tolerate that, and even with a slightly unpleasant few days, do turn up again a year later for the next infusion.
Good, because people worry, don't they, sometimes, that if they're having something straight into the vein, that once it's in, we hear it's in and I can't stop it, and I'm worried about that. So what you're saying is it's a temporary problem, one that usually goes away really quite quickly and is actually not as likely to happen the second time. So not to worry too much about that. Is that right?
The side effect profile tends to occur only when the medication is within the bloodstream. But this medication binds into your bone, and once it's within the bone, it doesn't cause any general side effects. So we don't have to worry about those beyond the first 2 or 3 days.
Right, that's very helpful. Thank you. Now, another thing we hear about is people saying they're worried about aching muscles, that these drugs might cause an aching muscle type pain generally. Is this a side effect of bisphosphonates?
Well, aches and pains are extremely common, and we all get them. And in studies, people are asked to report every little side effect that they think they might be experiencing, even those on placebo medications in a study, not on the active agent, may well complain of aches and pains. So aches and pains do occur. Perhaps they're related to medication. We're not 100% sure. I suspect in a few patients, a very small number, they do actually get aches and pains, or arthralgia, as we would call it medically. Again, stopping the medication and seeing whether the symptom goes away is a good bet initially, to find out whether it is your medication that's giving you aches and pains. But usually, if you do have some aches and pains with a medication, again, it's only around the time you take the medication, and it usually can be prevented by taking some paracetamol at the time. And it's very rare that you would need to stop the medication because of aches and pains.
That's helpful. Maybe you could talk a little bit about Denosumab, which is the different drug that you explained earlier. Is that one we sometimes people worry that makes their bones ache? Again, you were saying you didn't find that was a common problem.
Yes, no, I personally have. I've treated many hundreds of people with Denosumab, and it's certainly not a complaint that my patients have had. Denosumab is a medication, like all medications, that you could be allergic to. So you could develop a skin rash after taking a new medication, and clearly you would not proceed with the medication thereafter. But otherwise, people tolerate Denosumab very well. And occasionally people feel a little bit squeamish when they have the injection, or perhaps a little dizzy. But remember, it's only an injection once every 6 months, and the side effects are only at the time of the injection. I have an occasional patient who complains of urinary frequency after their Denosumab injection, and I think we can reassure you this is not due to infection. It's probably just an irritation of the lining of the bladder, and again it settles within a few days, although again only occurs very rarely.
That's helpful. And we do know that Denosumab is something called a biologic medication, and sometimes people ask, as they've heard that those sorts of drugs are linked to infections, but there's only some very specific infections, aren't there, that this drug could possibly increase the risk of? Absolutely.
We again, it's still very rare, but an infection within the skin, a cellulitis, has been reported as occurring more commonly in people who take Denosumab injections. I personally have never seen it in any of my patients, so it clearly is very rare. But yes, it's a biologic, and some biologic medications, such as those used to treat rheumatoid arthritis, for example, they do increase their infection risk. But the pathways that both Romosozumab, the other agent we might talk about, and Denosumab, pathways these work through, do not increase your overall infection risks.
That's great. Thank you. Right, we've talked about these sort of general side effects. Let's move on to talk about the much rarer side effects, which are sometimes called health risks. So these are sort of other health conditions that might be caused or prompted by one of these medications. And the one we get asked about a lot is something called osteonecrosis of the jaw, which sounds terrible, ONJ. Can you just explain, Dr. Black, a bit about what is this condition and how it might be managed, or does it get better?
Osteonecrosis of the jaw is an extremely rare condition that occurs in the general population, about 1 in a million of us, usually after a dental extraction or a dental implant. And it's when there's a small area of exposed bone in the jaw which doesn't heal over. And that can be very painful, can be prone to infection, and it takes quite a long time to heal. 18 months, 2 years are not unreasonable figures before it is healed up. So it's not pleasant if it happens, but it is extremely rare. And it doesn't, and although whether bisphosphonates truly increase the risk is not entirely known, but it's thought that they probably do, but to a very small extent. It's important to know that bisphosphonates are used to treat cancers as well as used in the management of osteoporosis and to reduce our fracture risks. And when we're treating cancer patients, those patients are often rather poorly. They often have other problems with their gums and their jaw. And the doses of bisphosphonates that are used under those circumstances are very, very much higher than we would use in clinical practice. And therefore, the incidence in oncology and cancer patients is perhaps around 1 in 1,000 patients might be predisposed to develop osteonecrosis of the jaw. Again, usually only after a dental extraction, although it can happen just out of the blue. When we're dealing with bisphosphonates for osteoporosis, be they tablet forms or injectable forms, we think the risk is somewhere around the 1 in 10,000. It may be increased in those who are on concomitant and also on steroid treatments, and in those perhaps who have things like peripheral vascular disease, bad circulation. That might make this slightly more common, but it is such a small risk. And I really think that the risk of you having a serious fracture is so much higher than your risk of developing anything such as osteonecrosis of the jaw.
Right, okay, that's really helpful. So we're talking about a risk between 1 in 1,000, 1 in 10,000, maybe even less. And as you say, it's those people taking the drugs for cancer who are at that kind of the higher risk end. And it is a bit confusing because people hear a lot about dental checks and so on. So let's talk a little bit about some of the things that are recommended to reduce the risk of this ONJ, even though, as we're saying, it is a low risk. Can you just take us through some of the general things that are recommended just to reduce that low risk and make it even lower?
Well, the first one is, of course, we should always look after our teeth. We only get the one set as far as we know. So you should have good dental hygiene. You should brush your teeth regularly. If you wear dentures, you should make sure that those are well fitting. And you should see your dentist regularly, once every 6 months. But then that's the advice we should give to everyone. We should all be doing that. From the point of view of being on bisphosphonates, it's important to tell your dentist that you're on a bisphosphonate medication. I don't think it's essential to see your dentist before you start a bisphosphonate. Just at your next appointment, tell them you're on bisphosphonates and explain to them that this medication is probably going to be ongoing for at least the next 5 years. Your dentist should then assess your mouth and assess what your risks are of requiring an extraction within that period of time. We don't recommend you have teeth out unnecessarily, but please, have your teeth well looked after, get fillings in a timely fashion. Those do not increase your risk of osteonecrosis of the jaw, and just have good dental hygiene. Some dentists are quite anxious about osteonecrosis of the jaw. This is something that they hear about in their own literature and they worry about, but it is incredibly rare. And if your dentist seems very worried about this, then perhaps you should give them the details of the doctor who's prescribed this medication for you, and they could contact your local osteoporosis service for further advice. there are some good guidelines out there for dentists as well. I'm Scottish, so we use the Scottish Dental Association guidelines, and I think they're actually used quite widely in the UK. And they're excellent, and they very much say that we should see our dentist regularly. We shouldn't panic about this. Yes, you can have your teeth out if required, and you can have all standard treatment. And they reassure the dentist that they should just continue with normal care. You don't need antibiotics when you have a tooth taken out unless there's another reason. You don't need to attend a hospital dentist to have a tooth taken out if you're on bisphosphonates, unless there's another complication which would always have led you to require hospital care.
That's very helpful. Thank you very much. And I think it's something people need a bit of reassurance about because they're reading and seeing so much out there, particularly in the media. OK, thank you. Let's just talk a bit then about the other rare adverse or side effect. And that's something which is called atypical fractures. Can you just explain a bit about what is an atypical fracture and how common are they?
Well, first of all, they're incredibly rare. We're not entirely sure why these things happen. They are probably more common the longer you're on bisphosphonates. They're probably more common in the Asian population and possibly also for those who are on corticosteroids such as prednisolone. But not a tremendous amount is known about why they actually happen. So your own individual risk is really very low of this occurring. And it is estimated that we managed to prevent 150 hip fractures for every atypical femoral shaft fracture that occurs. They're fractures, as you say, in the thigh bone, so below the actual hip area. They tend to occur spontaneously, although in around half of the patients, they have an ache in their thigh before the fracture occurs. They also, if they're going to affect one side, they're more likely to also affect the other thigh bone as well. So if you were to have an ache in the thigh and you thought, well, I just don't know, could that possibly be, then you should present yourself to your general practitioner, and your general practitioner will usually arrange an X-ray to exclude an atypical fracture, because they do have little changes within the bone before they do actually fracture. So it is possible sometimes to pick these things up. And actually more recently, the scans we have done to look at osteoporosis, the DEXA scans, they can actually have extended scanning options, which we have, for example, in Aberdeen, where we scan down the whole of the thigh bone and we can pick up little abnormalities before they develop. And there's quite a lot of evidence if you were to pick them up early, you could stop the bisphosphonates at that time, make sure everyone has plenty of calcium, vitamin D in their system, and then might be able to prevent the fracture occurring. And that's certainly something we do in Grampian. And it's also important that if you do pick up something that might be about to happen, is to ask one of our orthopaedic colleagues, our orthopaedic surgeons, because it's much better to do something about this before it fractures rather than waiting for it to fracture. But as I say, these are incredibly rare, and we perhaps see in my practice, in a population of 600,000 people, perhaps one of these a year. And I perhaps see two people overall with osteonecrosis of the jaw, and usually those are due to oncology purposes rather than osteoporosis. So these are very, very rare events.
That's really helpful. And so you're saying one way to reduce the risk is to just beware if you get this unusual groin type pain or thigh pain. What other sort of small things can people really be doing to reduce their risk of atypical fractures? Is there anything else that happens in practice?
Yes, well, I think it's important to remember that when we're talking about treatment of osteoporosis overall, we're by and large talking about lifetime treatment. So therefore, that treatment is likely to be intermittent, but continue for many years. And there's a lot of evidence, particularly using bisphosphonates, which are very long-acting agents, that it's better to have short courses of bisphosphonates with a gap and then reintroduce them. And it's believed that that might reduce the incidence of these more serious side effects, such as osteocrosis of the jaw and atypical femoral shaft fractures. So therefore, usually when you start a bisphosphonate, there's a recommendation that you have a repeat bone mineral density assessment in around 5 years' time to ensure that you still need the therapy, first of all, that the therapy is actually causing improvements in your bone mass. And the report may well suggest at that point having a gap in therapy, perhaps for 2 years, and then restarting the therapy perhaps for another 5-year course, or even longer. If you've had a good response to the therapy, you may not need treatment perhaps for 5 years. So we shouldn't consider that when we start a bisphosphonate, it's for life. I think that's not good practice. We should be having follow-up and recommendations. There are, of course, some people who have very severe osteoporosis, and we do not give gaps in therapy, but there we suspect that their risk of fracture is so much higher than the risk of any of these possible side effects that we would continue therapy. But that would be a discussion that would occur with you and your osteoporosis doctor.
Thank you. Very, very helpful. And I think that's setting out and covering all the sort of issues that people ask us about. Okay, so let's just move on to a couple of other things. I just wanted to talk a little bit about Romosozumab, a very much newer drug which is now available. And it's for those who, particularly those who are already breaking bones with osteoporosis. The side effect we hear about, or the health risk, is that it might cause a heart attack, which is obviously worrying for people. Is this a problem? And who does it mean these drugs are not suitable for? How do you decide that with your patients?
Well, Romosozumab is a very new therapy. Again, it's an antibody against one of the metabolic bone pathways, and given by an injection, and the treatment lasts for a period of 1 year in total. So it's only recently been licensed, but in Scotland we were licensed slightly earlier than than in England, and I've treated around 100 people with Romosozumab so far, and with some excellent results. So it is an excellent therapy, and that's what we must remember. It does prevent fractures really well. There were 2 large studies done before this medication achieved its license. And in the first study, there were no cardiovascular concerns raised at all. And cardiovascular is things like heart attacks and strokes and angina. In the second study, there seemed to be a slight increased risk of you going on to have a further heart attack or stroke if you'd already had a heart attack or stroke in the group using the Romosozumab. Now, it was a very small increased risk, but it was there. The biological reasons for this are unknown, and because of that, there is a lot of scepticism within the healthcare professionals whether this actually is a true outcome of taking these medicines or not. But the license for the medication is that if you previously had a heart attack or stroke, you should not be given Romosozumab therapy. Certainly in my practice, before I recommend any of these medications, I read the patient's electronic record. Everything's electronic these days. So I look at what medicines the patient is on, whether they've previously had a heart attack or stroke, do they have diabetes, do they have high blood pressure, are they on treatment for their cholesterol? And your doctor should look at all these things and look at what your risk might be of having a heart attack or stroke. And I truthfully only offer Romosozumab to patients where I'm comfortable that their risk is not exaggerated by having this medicine. But certainly it's a conversation you should have. If you're at all concerned about this, then have that conversation if this medicine is offered to you. And remember that not taking treatment has consequences as well as taking treatment. So fractures of spine, hip, and peripheral fractures, not doing something about your osteoporosis is not a good idea either. There are lots of medicines for osteoporosis, and it's important to find the one that suits you at this point of time in your life. And you may be offered other medicines in the future, and new medicines might appear, but doing nothing is rarely a good option, in my opinion.
Okay, that's great. Good summary. And we've just got one more side effect I wanted to mention, which we do get asked about, and that's hair loss. People read that hair loss is on the list as a side effect. And is this a real problem? And what's your experience there? Yeah,
well, I think hair loss is a problem as we get older, and we need to recognise that, particularly in postmenopausal women. Hair often changes, goes grey obviously, but it often becomes wiry or much thinner. So perhaps these changes are just because you're getting older. But if you do think that, and it's usually with bisphosphonates we hear this, if you do think the bisphosphonate is causing hair loss, please be assured that if it is the bisphosphonate and you stop the medication, your hair should recover. It's not a permanent side effect. And I think in some individuals, bisphosphonates do cause hair loss. I think it's very rare, but I think it does happen. And I think usually under those circumstances, all bisphosphonates will do the same. It's something about you and bisphosphonates that don't mix. So I would stop the medication under those circumstances and consider discussing other medications for osteoporosis. And I don't believe hair loss occurs with those. At least I just don't think there's any evidence to support that.
That's really helpful. Great. Well, I think we've got to wrap up now. So much useful information, Dr. Black, that you've given. I know it's going to make our listeners feel better informed, and hopefully you're able to make the right decision for them around taking a drug treatment. Obviously, you're going to have your own preferences and your own needs, but getting the information and to help you make decisions is so important. Do talk to your healthcare professional if you feel you need to know more. Call our helpline, talk to our specialist nurses, and have a look at all the other information that's available on our website. All that's left to say is thank you very much, Alison Black, and thank you, our audience, for listening. And we'll see you again on our next Bone Matters session.